everyone. My name is Scott Tagawa. I'm a medical oncologist at Weill Cornell Medicine near Presbyterian. And I'm very happy to be here today to be joined by my colleague. Go ahead and introduce yourself.
Hi, I'm Valentina Marulanda, medical doctor, and I currently work as a postdoctoral research fellow in the Division of Molecular Imaging and Therapeutics at Weill Cornell. And I'm happy and glad to work and collaborate with Dr. Tagawa as one of my PIs here at Cornell.
Great. I'll give an editorial commentary that I think she's a rising star. So, we're in the era where we have validated PSMA as a target, both diagnostically and therapeutically, and the currently approved therapeutic agent is lutetium PSMA 617, which is able to, we think, kill cells because of the beta emission, but there's also gamma emission from the lutetium, which we can see. So you had a presentation, and congratulations on the award that came with the presentation at SNMMI 2025. So can you describe, some of our viewers may not understand fully what SPECT or SPECT-CT is, and then, so what is that, and then how is it used?
Okay, so as you very well explained, thanks to the properties of lutetium and the gamma emission, we can perform SPECT CT scans and determine how much of the injected dose is absorbed, not only by the tumor, but also by normal organs. So currently guidance determined that SPECT-CT dosimetry should be performed at multiple time points. But the downside of this is that multiple time points is time consuming and generates a burden to the patients, their families, and also the healthcare system, because it is stated that there's a need for at least 3 to 4 time points. So patients have to come back to the hospital after the injection, usually 24, 48, and even 92 hours after treatment. So this project was mainly about trying to look at a single time point that is also useful, and from this single time point, if we can get clinically meaningful and impactful information just to decrease the burden to the patients and their families and get clinical information from this. So we also try to correlate not only absorbed doses to tumor, but also the correlation with PSMA PET at baseline, and we try to give a glimpse to correlation with clinical outcomes, for example, PSA 50, which has been proven to be associated with decrease after lutetium therapy.
So I don't think you fully described, so the single time point makes absolute sense, much easier on the patient, as long as we get the useful information. I don't remember if you described the 2 different time points. So describe the 2 different time points that you tested and then what you found.
Yes, so we tested 2 time points. One was 4 hours after injection, and the other one was 7 days after injection. And we compared this with tumor absorbed dose mainly. And what we found is that at earlier time points, meaning 4 hours after injection, the tumor absorbed doses were significantly lower compared to later time point at 7 days. At 7 days, SPECT-CT dosimetry demonstrated higher tumor absorbed doses. And when we did this comparison also to healthy organs, we didn't find any differences between 4 hours and 7 days. So the conclusion for this part of my presentation and our work was that at later time points, we are seeing higher tumor absorbed doses compared to earlier time points. And also we try to compare these 2 time points with PSMA PET at baseline parameters, meaning SUV mean, SUV max, and total tumor volume. And what we found is that in general, doesn't matter the time point we pick, 4 hours or 7 days for our whole cohort, there's a moderate correlation with baseline PSMA parameters, mainly SUV mean and SUV max. And when we performed the subgroup analysis, we found that these correlations were higher and the statistically significant p-value was even lower at 4 hours at earlier time points, meaning that the correlation between baseline PSMA PET and SPECT dosimetry performed at 4 hours, the strength of correlation is higher. And when we look at this at 7 days, we found that the strength of correlation not only decreased, but also stopped being statistically significant. So one of the main conclusions of this project is that probably earlier time points are best for determining delivery of the injected dose to tumor and healthy organs, and later time points are better at assessing retention, mainly because the tumor absorbed doses were higher at 7 days.
But I think that's important. I would say so this is a radioactive type of a treatment. And I think that every doctor, regardless of the type of doctor, if we're thinking about, external beam radiation or brachytherapy, is it's not even thought of to do that without dosimetry. So it makes sense that we'd want to employ this for quality control. But you also had some results in terms of what you saw from the SPECT and the efficacy of the drug.
Yes, so we also try to look at PSA 50 and its correlation with tumor absorbed doses mainly. And we found that patients who achieved at least 50% decline under PSA after treatment had higher tumor absorbed doses. So meaning that as much as the dose is going to the tumor, patients are having better results. We also want to look at survival, progression-free survival, and overall survival. I think these are next steps for us to look at and try to look for any differences between earlier time points, 4 hours versus 7 days. And if we find that 4 hours is not inferior to 7 days, then why not do everything in just one visit for the patients and their families? They usually come here, they go to you, to your office visit, then they come to us, to our nuclear medicine department for injection, and they say in just one visit, one day, they get everything done and they don't have to come back to multiple visits, considering these are patients who are dealing with a lot and their families, and also all the restrictions like radiation safety and all the precautions they have to have.
Yeah, you started off with some of the background on traditional dosimetry, which is typically 3 to 4 different time points, which is clearly not convenience, but that's done as part of research, and hopefully, the patient/subject and their family is contributing. Hopefully we can also reimburse them for their time and effort. This is real world. They're getting treatment. So hopefully they're getting, the benefit from treatment. Of course, there may be some side effects, but if we can also use this to give some prognostic information, or everything you talked about right now with cycle 1, cycle 2, 3, etc., also is a PSMA image, so we can see the effect of prior cycles as a different type of an aim, then I think that is quite useful with a single time point. And I know from personal experience dealing with many patients and their families, some, they don't really care. They live close and they can come here. They're retired and they can come anytime. Some, they really want to do everything in one day. And some, they'd rather get treated, go home. And since they're going to come back in a week anyway to see us to assess what's going on with toxicity, then they prefer that. So it's partly a choice. And I think one nice thing you've shown, even though there may be a little bit of difference with same-day imaging versus 1 week imaging, it seems like at least one of those is feasible for most patients and probably better than nothing. We just have to learn how to interpret that data. So you mentioned briefly, or hinted at least, in terms of what next steps might be, but what do you think the real next steps are with this project?
Okay, so looking at progression-free survival and overall survival associated with tumor absorbed doses, and also something that is like a big and hot topic about radionuclide therapy are toxicities. So if we can look at absorbed doses to healthy organs and try to correlate that with toxicities, maybe we can get to that sweet spot when eventually in the future we can assess how much dose should be given to a patient according to the absorbed doses, and also trying to avoid toxicities. So I think all this project and all the dosimetry efforts that we are doing here and also in other places in the world is just trying to move forward towards precision medicine and personalized therapy, because what we believe is that 200 millicuries is probably not a recipe for all the patients. And maybe some patients, given some other factors, have higher absorbed doses to tumors, but also there are others that have lower absorbed doses and maybe higher toxicities. So there are many factors that come into play, and if we can determine how all of them play together and how we can better create treatment plans for patients that are more personalized, I think this is a good tool for us that is not as well explored as we should be doing it. And yeah, I think that's where we are going and moving forward towards.
Yeah, I agree that essentially all of us, doctors and patients alike, are very interested in precision or personalized medicine. And this type of a therapy is fairly unique in that we can actually see where it goes, and then also see the effects. Anything, we can have side effects and we adjust, the dose of chemotherapy, for instance, but this is something we actually see. So thank you very much. I think that I'm biased, but I think that you have presented some very interesting work, and we all look forward to watching your follow-up work and in your career. Thank you very much.
Thank you. Thank you so much.